Rico, that bobblehead Batman background makes me laugh every single time I see you get online.
Chris, I live for your amusement.
It's a great combination. Love it. All right, so it looks like we're still waiting on a couple board members. So hopefully they'll log in here within a minute and we can get started. It looks like we're still missing two of us, right? Am I seeing that correctly? Missing Jan and Kaya. Let's just give them another minute so they could jump on before we get started. All right, well, we are already a minute over, so let's get started. And then hopefully those final board members will pop on here. First of all, I just want to welcome everybody to the January 31st Special Board of Health meeting. And I'd like to thank everybody for joining, staff, and of course, those who are attending from the public. So Renee, do you want to start and begin the roll call for us, please? Oh, Tom, go ahead. I see your hand.
I was just going to mention, Julie, that the Arapahoe County Commissioners have asked all three representatives to stay on through the end of the year. So we'll be with you through 2022.
Great, well, thank you. I continue to look forward to serving with you guys. All right, Renee, you want to do the roll call for us?
Yes, I can go ahead and do that. I'm just looking for Jan. It looks like she's having trouble getting on. So do you want me to do roll call right now or just see if I can get her in?
I'm on.
I see her. There
I'm
she is. Yep.
All right, you made it.
It only let me in as an attendee. Sorry.
Nope, you are good. All right, I will go ahead and start roll call. So please state present after your name is called. Representing Adams County on the Board of Health, Julie Mollica.
Present.
Rosanna Reyes,
Present.
Julie Schills,
Present.
and representing Arapahoe County on the Board of Health, Jan Brainerd,
Present.
Dr. Thomas Faywell,
Present.
Dr. Kaya Gallagher. And I'm not seeing Kaya. Am I missing her or?
I'm not seeing her either. Is she perhaps an attendee that needs to cross over?
Let me just double check very quickly. Oh, I do see her. All right, good call, Julie. We have Kaya joining us now. So Kaya, we're doing roll call. So if you could state present, we can go ahead and move on to the Tri-County Health Department leadership.
Present, thank you. I was not a panelist, but thank you.
All right, Tri-County Health Department leadership, Michelle Askenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner, Director of Community Health Promotion.
Present.
Lisa Bolstad, Administrative Assistant.
Present.
Jill Bonchensky, Director of Nutrition.
Present.
Amrane Brockman, Executive Assistant. Monique Didier, Director of Administration and Finance.
Present.
Dr. John Douglas, Executive Director.
Present.
Maine Furman, Director of Human Resources.
Present.
Penny Grandy, Director of Nursing. Brian Halavasek, Director of Environmental Health.
Present.
Jennifer Ludwig, Deputy Director.
Present.
Dr. Kelly Weidenbach, Director of Planning and Information Management.
Present.
Roll call is now complete.
Awesome. Thank you, Renee. All right. So first of all, welcome to everybody on this call. Thank you for joining. Members of the public, thank you for joining us. Just a short reminder to the Board of Health members, please use the chat function or raise your hand if you'd like to ask a question or provide a comment. And for those members of the public that are joining us, we encourage anyone who has questions, please visit the Tri-County website that has updated guidance documents as well as answers to frequently asked questions. The website also has Tri-County contact numbers as well if you prefer to contact us that way. During tonight's meeting, if there are any questions from members of the public, please use the questions and answers function on this platform. Your responses will be available to the Board of Health as well as the Tri-County Health Department staff. We are not doing a public comment period during this meeting tonight. We are going to be moving on to really our only discussion item of this evening, and that's from Executive Director John Douglas, who will be providing us with an update on the Tri-County Health Department mask mandates for the board. John?
Yeah, thank you, Julie. Thanks to the board for convening quickly for this special meeting. Thanks to the members of the public who have joined tonight, as well as those who've been emailing Tri-County and board members. Your engagement with your opinions is an important part of our understanding the context. And a special call out and thanks to two special guests tonight, Superintendents Chris Kadowski and Rico Munn, who agreed to join us to answer some questions that will address, I think, some concerns about what happens if school mask mandates end to vulnerable students. And they've been like A+ partners of Tri-County during the past 2 years, and I really appreciate their taking the time to join us. Lisa, can you pull up the slides for us, please? While Lisa is doing that, let me say that I will talk about 5 topics. Our trends in COVID-19 cases and hospitalizations, some recent modeling results from the School of Public Health modeling team. If you can put it on display mode, Lisa, that'd be great. Some considerations about ending the mask mandate. Some of this I've shared with the board by email, and we'll go over that again tonight. Again, I want to have some, next slide, please, Lisa. I want to have some perspectives from our guests, Chris and Rico, and then finally a recommended motion from me for the board to consider. Next slide, please. This is taken, unfortunately, I think this is yesterday afternoon. We didn't get it. I didn't get a chance to update it today. A quick facts part of the Tri-County dashboard that allows you to see what's happening with 7-day incidence rates by county over the past 2 weeks. It does have Douglas on here because we still track their data, but of course we're talking about Adams and Arapahoe tonight. I think the key thing I want you to focus in on is the current numbers. So 7-day incidence rates per 100,000 for Adams, 646, Arapahoe 621. That actually has dropped today. I did get a chance to check it just before the board meeting. Those are both in the 570s and 580s right now. The second thing I'd like you to focus on is over this roughly 2-week period of time, what a fairly dramatic drop has occurred in cases from the 18th, Adams County 1437 down to 646 today, Arapahoe 1500 down to 621. Our peak day was actually January 11th. That's when almost like, I don't know the right metaphor, the Washington Monument, something with a big point on the top that's really skinny. Things peaked and then began to come back down. We were in the 1800s on those days. And honestly, over that period of time, which is 19 days through yesterday, we've dropped by over 2/3. So nothing short of a unprecedentedly dramatic drop. Next slide, please. Excuse me. Data taken off the Tri-County dashboard. And I'm sorry, these data, because our team had some problems with the server over the weekend. I couldn't update all the slides. Has not been updated since I think the 25th. But the different colors are different age groups. I'm not going to read them out. They're across the bottom. The big bottom line is everybody's moving the same way. Whether you're in the most at-risk group, the 18 to 20-year-olds, which got up to the highest level, or whether you're at the least at-risk group, the 65 to 74 and the 75-plus-year-olds, the brown and the gray at the bottom, respectively, everybody peaked on almost, not exactly quite, but almost the same day. And everybody's had a very similar declining slope since then. Next slide, please. This is a slide presented by Dr. Herlihy, state epidemiologist, last Wednesday. So it's a little out of date. And Rachel has given us periodic updates about what's happening with the case trajectory in different locations that we know have experienced a pretty bad Omicron outbreak. Note that the x-axis are not dates. These are the days prior to the Omicron surge. Day 0 is the day that Omicron is estimated to have started in different places. That was approximately December 18th in Colorado. And then moving on from that 0 point to the rightward is the number of days after Omicron started. Colorado's in purple. Denmark is, which is the one still going up, is in yellow. The South African province of Gauteng is the green at the bottom, and then sort of mixed in, a little hard to sort out from each other, are London, New Jersey, New York City, and the US as a whole. The key point of this is, except for Denmark, pretty much all of the peaks occurred approximately day 28 to day 35. It's not exactly like clockwork, but it's pretty much like clockwork in terms of how up Omicron went and how down. So if we started on the 18th and we peaked on January 11th, that puts Colorado actually even a little better. That's about 24 days, but it's within the range of what's seen in other places. That's point number one. Point number two is that except for a slight flattening that's seen in London, pretty much all of the places that went up have continued to go down quite consistently. Now, what's going on in London, and maybe, by the way, what's going on even more importantly in Denmark, and what's thought to be happening in Denmark is the emergence of a related variant to Omicron. Omicron is technically called BA1. It's got a very closely related subvariant that's called BA2. And the Danes, who have the best sequencing capacity in the world, have been able to tell that BA2 has come into Denmark and caused a fairly big change. The data from Denmark so far suggests that BA2 is probably as or more contagious than Omicron. It is probably prevented by vaccines. or natural infection with Omicron, even though that's still being sorted out. It does not appear to be any more severe. It also appears that that's what's happening in the UK, or in London rather, where you've got that flattening. And I do want to point out that, as I think everybody knows, the entire time of living with COVID has been punctuated since about a year ago with the emergence of new variants. And the last thing any of us should be thinking as we see the kind of improvement we're seeing is it's all over, never again. It's a coast home. So we do have to be vigilant to new variants. It's possible those new variants may even cause us to have to change vaccines in the future. But at least the experience with Omicron in most places, and now you could superimpose Connecticut, Rhode Island, Maine, Massachusetts, Maryland. I just looked at all those this morning. They look very similar to the trends in New York, New Jersey, and other parts of the Northeast. Next slide, please. Now, these are data that our analytics team, I want to particularly call out Robin Hart, who's sort of been leading this effort, has been looking at to try to help us do incidence rate projections in our 2 counties. So you've got that skinny little needle-like peak there in approximately January 11th. And then what we have seen in the black lines is not exactly completely, totally linear, but about as close to linear as you will ever see in a biologic phenomenon like a pandemic. The dotted blue line, they began doing this about 2 weeks ago, trying to project if things drop in a linear fashion, where would we be at different points in time? Now, the table at the bottom left shows you where we actually were at different points in time. So on Friday the 28th, we were 729, 759 in the 2 counties respectively. They projected on Friday afternoon, we'd be at 557 and 584. We're just above that, 573 and 571 respectively, because they're really scientifically precise. They want me to be sure to remind myself and all of you that nothing is ever linear biologically. And while this has been a pretty good prognosticator, as slopes begin to go further and further, they may or may not follow a linear trend. So I just want to, in full transparency, give you the caveat that the assumptions may be less accurate towards the end of the curve as it begins to flatten out. Nonetheless, so far, it has remained more linear than at any point we've seen in the pandemic. And it looks very much like what's happening in the northeastern states that I just mentioned. Next slide, please. So that's cases. Cases are really important. But what about people getting sick? These are data from our syndromic surveillance system that looks at syndromes that are compatible with COVID in emergency room admissions and in hospital admissions. The solid yellow line going all the way back to the beginning of the pandemic shows you how those 2 measures taken together have modified over time. What I wanted you to see was just how even actually before we saw that case spike, we saw a severity spike as measured by the syndromic surveillance system. And I think this is important because I think we all know that some of the hospitalizations that I'm just going to refer to in a minute have been somewhat accentuated by people who test positive when they get admitted to the hospital with heart attacks and broken legs, but don't necessarily have COVID illness when they get in the hospital. This, I think, is one way to try to sort that out. These are not test result based because we can't get that kind of test result real time. But because it's so syndromically compatible with COVID, we think it's paradoxically providing another sort of element of triangulation as to what's happening with the severity part of the Omicron wave. Next slide, please. These are state data on hospital statistics. This is hospital census on the left, how many people are currently hospitalized for COVID, and new hospital admissions on the right. These are from Friday. State hasn't updated its data through the weekend. I'm showing you state data, not tri-county data, because we discovered last summer that what we thought would be a really fantastic metric, new hospital admissions, was a really good metric at the state level and not a great metric at the local level for real-time decision-making. Because these data come out of a system called EM Resource that the state has access to, but which is not subdivided by county. So state data, but again, showing you very similar, both in terms of hospital census as well as new admissions on the left and right respectively, how hospitalization, again, the metric of severity we follow most closely, has been dropping. Next slide, please. Now, the metric that we got, I think, appropriately most focused on just before Thanksgiving, when we began to worry about ICUs having insufficient capacity to care for patients, was how many ICU beds we have. We've been using data from the North Central region. This is one of 10 emergency preparedness regions in Colorado. It includes all the metro area. This is looking not at hospital capacity, which I'm going to show you in a second, but rather hospitalizations in the North Central region. And as of, I think it was Sunday, I guess it was Friday, there were 743 folks in our 10 county emergency preparedness North Central region. The 743, as you can see, is substantially lower than it was right before Thanksgiving when the indoor mask mandate went into effect. It's a lot lower than the 1035, which was the peak, again, of number of people in the hospitals during the peak of Omicron. And you'll notice that 1035 is even higher for the North Central region than the worst days of 2020. Again, remembering some of these folks are people diagnosed with COVID who aren't sick with COVID. But I think those trends show you from a regional perspective, which is the unit or the geographic unit for which we're measuring hospital capacity, just how rapidly things have improved. Next slide, please. So these are data that we show you on our website every day. These are the data that when we established the indoor mask mandate, we've been tracking. It's the percent of staffed ICU beds in the North Central region. You can see the counties listed above there. The point to be made here is that we have not yet hit the greater than 10% capacity for 14 straight days yet. But we have since January 16th begun to see the greatest sustained increase in hospital capacity since we began using this as a metric just before Thanksgiving. In fact, we're now 3 days in a row, we have in fact had more than 10%. I haven't seen today's data yet. I don't know if it'll remain that way. I think the trajectory suggests that it probably will. That'll be day 4. So we've had now 2 weeks of sustained improvement, not above the metric that we set up originally, but certainly about this important issue. One of the things that I think it's important to point out is that when we set up this metric, we were in the middle of the Delta wave. Delta was, as I think you're aware, as it turns out, a much more severe variant, much more likely to put people into the hospital. Biologically, it's probably because Delta replicates more readily in lung mucosa than it does upper airway mucosa. Omicron's the opposite. We tend to get more milder upper respiratory infections and less severe lower respiratory infections. That is what puts people in the hospital. The reason for pointing that out is I think, everybody knows friends who've had bad colds and they turned out to be COVID. One of the implications for this metric, however, is the direct relationship between ICU capacity and what's going on with COVID in the community is somewhat less tight than it was with Delta, because a much smaller fraction of those who actually do get hospitalized with Omicron end up going to the ICU. Durations of stay are shorter. Those who need to go to the ICU are less. And my colleagues who track the data from the North Central region tell me what's happening is that more and more the ICU capacity is being filled up by folks with non-COVID related illness. Let me remind you again, I can't get data on ICU capacity by COVID. I can only get it by all players. So that particular metric has become, I think, more loosely related to COVID prevention efforts in the community. Next slide, please. These are data to give you a little bit of flavor. This is from Rachel Hurley again. It's the state's estimation of what fraction of all cases we're actually diagnosing. And they are doing some sort of fancy footwork. That sounds demeaning. It's statistically pretty thoughtful using state reporting data in CEDARS and electronic lab reporting data to estimate in the gray how many cases are actually happening versus those that we're actually diagnosing in the blue. The key point here is that when I show you some of the modeling data in a few minutes, we have strong reason to believe that a lot more people have already been infected with Omicron. And that would be pretty much everybody infected since approximately December 18th. Then we're actually measuring. And so when I talk to you a little bit about immunity-related Omicron infection, this is to sort of set you up to understand that while case counts have gone up dramatically in an unprecedented way, they don't capture the full story. Next slide, please. And in fact, this is the story I wanted to refer to, and this is the first slide from the modeling group. I've got about 4 or 5 slides here. Very interesting to see what they estimate immunity in Colorado to look like now. And that at this point, they estimate, this was as of last week, that Omicron immunity had reached 75% and still rising. And nice sort of summary on the right side of the slide. At the end of 2020, before vaccines had begun at all, less than 20% of the population was immune. By the time we got to the summer, vaccination raised that to 60% or so. When we started Omicron, because some of the initial vaccine-related immunity had begun to fade, and because, as we've talked about before, our booster effort has not kept up with our original vaccination effort. And so we actually have had less vaccine-related immunity, and the modelers estimate that in early December, our overall population immunity may have been as low as 50. And so in the last 6 weeks, we've had the biggest jolt in immunity, again, largely through natural infection, up to 75% that we've seen since the pandemic started in a short period of time, with an estimation now that about half of the Colorado population has been infected with Omicron. Next slide, please. So as of last week, we still had really, really high prevalence rates. 1 in 19 is what was estimated to be actively infected with COVID. But what these projections show is that how case rates vary will depend on transmission control measures. If transmission control measures such as social mixing or the lack of masking, for example, that's the topic we're discussing today, drop off, we would expect to see more cases. That's the purple and the red. On the other hand, if they don't drop very much, then we would expect to see cases going down pretty rapidly. Next slide, please. But probably much more importantly, certainly for the consideration of the hospitals, is what happens with modifications of transmission control from a hospitalization perspective. And here, if you look at the 5% drop in yellow and the 50% drop in purple versus the blue line, which is if everything stays the same as it is right now, the modeled projection is there's really not a lot of difference. Maybe somewhat of a blip, but not an upward blip above what we've experienced if one has the largest drop in transmission control. But with those more intermediate drops, the line really doesn't do very much at all. This is so different than when we considered the indoor mask mandate back in November, and when the school presented modeling data and we looked at transmission control related parameters. They varied very, very dramatically, all in the upward direction based on just how much transmission control there was. And their explanation for why does this not make more difference is we have so much more immunity now. We were 50% around the end of November, the beginning of December. Again, we're up to 75%. That was as of last week. It's probably even a little bit higher this week. Next slide, please. So this is sort of their kind of big summary. I mean, I said a few minutes ago about half. What they estimated last Wednesday was 42% have been infected. And you all have heard me say this before, infectiousness and immune escape of Omicron led to high levels of infection. They estimate that we may have up to 2/3 of us infected by the end of the month. Very, very importantly, and that's why I put the red thing around it, it's estimated that the majority of those infected, or certainly the majority of the unvaccinated, have been infected. So if you look at who's been most susceptible to Omicron, it's not those who got boosted. Some of us got it. It's not those who had 2 doses but not a booster. Some of them got it. It's the unvaccinated folks. And I think this is important to keep in mind when we think about changes that may expose some of our unvaccinated population, kids in school, kids in childcare. There is a very high likelihood that a large fraction of those folks, because they had not been previously protected by vaccines, unless they were really completely sequestered, got infected with Omicron during the past month. Next slide, please. So they close out by, sort of doing what modelers do. They try to project. They always acknowledge, we know it's not perfect. Some of this is going to be wrong, but here's the best weather forecast we can get. Hospitalizations and infections, I think, are going to continue to decline. Immunity to Omicron is high and rising. Mid-February, they estimate 80%. Remember, again, that's higher than we've ever been during the pandemic thus far. That's going to lead to further continued decline. We don't really know, because these are models, just how fast it's going to decline. It's going down quite fast in London and New York and New Jersey. It's going down a little more slowly from a hospitalization perspective. Rachel didn't have those data to share with me, so I didn't show them to you, in Denmark and South Africa. So again, I want to be as clear as I can. I can't absolutely, because they can't tell me how hospitalizations are going to progress. But the trajectories have either been very consistently down or more of a milder decline, but all moving in the lower direction. Now, major caveat, the most important caveat since really last January when we first got vaccines are variants. They've always been the problem. They've always been the main cause of surges. We do not know when the next variant will emerge. We don't know if BA2, which has been identified in Colorado, is going to explode. We don't know if BA2 is going to smolder along. We simply have to acknowledge that uncertainty. One thing that does seem to be increasingly clear, however, by the way, is that Delta as a resurgence is quite unlikely. And again, it's not so much because Delta's gone away, but because Omicron actually does appear to protect against Delta. So if we're at the 60-65% range now and getting up to 80% by mid-February, the reemergence of Delta seems quite unlikely. And if Omicron protects against BA2, that's not clear. We would be unlikely to experience that as well. I think anybody who sort of looks ahead and says, oh, COVID, we're going to probably be living with COVID for a while. We hope it's going to get milder. We don't really know if Omicron is the map to the future. It might be, no guarantee. But we're almost certainly going to continue to see local and regional outbreaks of COVID. These are going to be most likely in unvaccinated, but these are going to happen. And so if we as a health department make certain policies, certain changes, or certain recommendations, and things get better, we just need to prepare that they may not stay better, that we will be, as we move into more of an endemic time, dealing with the very high predicted likelihood of more variants emerging. Next slide, please. So overall key messages from the modeler: infections and hospitalizations have peaked, going to continue to decline. High prevalence now 5%, but we probably have peaked and it's probably going to decline rapidly. Estimated to get down to 1% by the end of February. Hospitalizations likely to be declining as well, but there's more uncertainty around that than there is cases. And again, the silver lining of this terrible Omicron cloud that spoiled the holidays for so many people is immunity, high and rising, with 80% likely by the middle of the month. Next slide, please. Middle of next month. So let me transition to saying or thinking out loud with you guys about what's the implication of all this about the topic of the day, which is ending mask mandates. And I want to talk about 5 different elements that I think are important. Element 1 is the improving epidemiologic trends. Element 2, the growing levels of immunity. Element 3 is the increased access we have to prevention and mitigation measures. Element 4, frankly, is difficulty, at least for Tri-County and for some of our schools, in enforcing the existing mask mandate. And then finally, some thoughts about what is the right time anyway. Is the right time for changing mask mandates this week? Is it next week? It's probably not forever. And I think that's really the most important operative question on the table. When is the appropriate time to think about a transition? Next slide, please. So again, just to summarize the improving epidemiologic trends. So we've got these dramatic declines. They are frankly more dramatic than anybody expected. They're more dramatic than what the modelers predicted. And they've been going, again, I can't believe they're going to keep doing linear, but they've been going down linear for over 2 weeks now. And that our rates, both counties have declined more than 60% since our peak. We project now that rates could be under 400 for both counties by the 4th. The updated projection is it could be under 300 for both counties by the 4th. That we could fall below the CDC level of high transmission level, which is 100 cases per 100,000 over a 7-day period by next Tuesday or Wednesday, and fall below the level of moderate transmission by next Thursday. And then very importantly, case rates have been declining similarly across all age groups. We don't have lagging, for example, among the unvaccinated younger folks. Next slide. Again, this is a summary of what I've already just gone through in terms of the data. So an unprecedented number of recently infected folks. I've just given you the numbers. Up to 78% of folks were almost at 80% now with Omicron specific immunity. And very, very important to note that while infection from natural immunity, which I frankly have not been a big fan of counting as part of the overall protection scenario, because I've really not been comfortable from my 40 years of doing public health and virology that it was going to last as long as that from vaccines. It does appear that it's likely to at least provide a bridge to the warmer months of the year when COVID transmission has now for 2 years in a row been less of a risk. And this has been a worldwide phenomenon. Since current vaccines are not designed specifically to protect against Omicron, it's also possible that those who have natural infection might actually even have greater protection in the long run than those who haven't. I still don't think it's a reason to go out and have a COVID party or an Omicron party, but I do think it's worth acknowledging the biologic possibility that natural infection may be, for the short time period, even more effective than vaccination. Paradoxically, this might be of particular advantage to some of our relatively under-vaccinated groups. So, for example, our racial ethnic minorities in our 2 counties have had lower vaccination rates. We can't vaccinate 5-year-olds. I will tell you that among our Hispanic residents, with their lower rates of vaccination, they have experienced higher rates of infection during the Omicron surge, and at least, again, for the short period of time, probably have enhanced infection-related immunity. Now, that, of course, was not without cost. There were hospitalizations and deaths occurring with that, but if you made it through, you're probably in somewhat better shape for a short time period. And I also want to point out that a question that some have asked is that although recent data have indicated pretty strongly that for adults or adolescents who got their doses back in the spring or the early summer, you really do need the booster to give you optimal protection against Omicron. This is probably because of the lapse of time after the second dose. And thus, the recently vaccinated 5 to 11-year-olds, like my grandson, probably have levels of protection similar to older person who received initial doses many months ago. So they're unboosted, but they don't yet need a booster. So when we sort of think about what about the kids in elementary school, those who have in fact gotten both doses probably are equivalent to adults who've gotten boosted. Next slide, please. I also want to point out what we've talked about before, but I think it's worth reiterating. So vaccines are our best prevention measures. We've had them available for persons 5+ for close to 3 months. We'll hit our 3-month anniversary on February 8th because they became widely available on Monday, November 8th. But there's also increasing access to other important prevention measures that can be useful in both school and community settings. Particularly, we are getting over the logjam of inadequate access to rapid testing. And we have also gotten, I think we're well on our way of getting over the logjam of adequate access to higher quality masks, medical grade masks. And we also have finally the CDC coming out and saying, yeah, probably medical grade mask, surgical greater than cloth, KN95 greater than surgical, N95 greater than KN95. And we've got federal and state programs now more actively making higher quality masks available to residents for free. And although while not in nearly adequate enough supply right now, we've got a growing array of effective therapies with substantial ability to prevent serious outcomes. We've got therapies with at least one monoclonal antibody. 2 don't work against Omicron. We've got 2 oral antivirals. One is kind of so-so, molnupiravir. One is terrific, Paxlovid, in terms of preventing hospitalizations and death. There is not enough of them right now, but the supply is increasing quite readily. And I think this is going to be sort of helping us shape the future in terms of folks who either have breakthroughs or infections without having gotten vaccination. And then finally, it's worth mentioning there's a monoclonal antibody. I said post-exposure here. This is for actually pre-exposure for immunocompromised patients with severe impairments of immunity. Evusheld is actually now more available than sotrovimab, and it's being given out by oncologists and transplant surgeons for high-risk patients in their practices. Next slide, please. I want to note, not so much to show you the pictures of basketball games and whatnot that I think you, like me, have been receiving, but I just want to note the obvious that there has been difficulty in enforcing the mandates. At the very beginning, we said, look, this is mostly going to be educational. We don't run a police force. We're not going to give out tickets. We're going to try to help people understand why they need to do it. And if we have particular problems, we'll try to work with them. But I think what's happened since the school and then more recently the indoor mask mandate was initiated, we have seen, I think, more compliance fatigue. And this has been a particular issue for our staff, who are frankly, as I know our board knows, getting somewhat thinned out as the uncertainty with our 2 counties goes on. And while I don't want to speak for our superintendents, certainly what I'm hearing when I have weekly calls with them is that the same sort of issues we're having have occurred in schools, that mandating or rather enforcing a mandate in a public health order in some schools is working quite well, and other schools is much more of a challenge. Next slide, please. So a couple of, these are just my thoughts about the timing thing. And I want to acknowledge that while I'm going to make a recommendation to the board tonight about a particular date to make a transition, that's going to be a date of this Friday, I think it is fair to say that we don't know the perfect date. I've got a pretty good hunch and a pretty good public health judgment, which is why I'm going to make the recommendation to you. But I want to acknowledge that there's not a perfectly right answer. I think we have to consider the epidemiology, the seasonality, what mitigation tools we have, to consider when is the right time, not to give up on the mitigation that we've been doing, such as a high level of masking, but rather when is the right time to transition from this being required by a branch of government, a public health department, to other entities in the community, schools, businesses, churches, et cetera, and individuals themselves. Our schools have done a superb job of keeping their facilities safe for in-person learning over the past 18 months. And I think with declining case rates, really are increasingly in a great position to continue choosing which of the range of mitigation strategies that they've been using, promoting vaccines, promoting good ventilation, having those who are sick stay home, rapid testing, enhanced social distancing when you can achieve it in the school setting, face masking, to really figure out in which contextual circumstances they work the best. Schools have also, I think, clearly got the capacity to accommodate particularly at-risk students to prevent their education from being disrupted. This is not new territory for the schools. And in my conversations with the superintendent, it's reminded me I should not think I know how to do their job. I don't. They do know how to do their job, and they've got some great ideas. Next slide, please. So before we transition and talk about schools, I wanted to say that ending the mandates does not mean that we don't think masking is effective. We're going to continue to recommend mask use per CDC and CDPHE guidelines during times of high transmission, especially for vulnerable people. And underline this, masks are very likely to have an important role to play if future variants turn up that are not effectively prevented by vaccines in current use or prior infection. This is not where we, or whenever we end up no longer mandating masks, it's not because they're not working. They have very important roles to play, and those roles could be greater depending on the nature of a future variant. And I guess I also want to say we've had discussions on the board about, what's the end game, what's the off ramp, when does it become influenza? As serious conversations about transitioning from a pandemic to an endemic response, I called it here endemic accommodation, because it's going to be living with the various twists and turns COVID presents of what's likely to continue to be seasonal and variant associated upswings, and even potentially large outbreaks of COVID cases over the next months and years. I really do think that it makes sense to consider the community responsibility for wise and context-specific use of the range of mitigation strategies to be our backbone. I think it made sense for public health departments to do the admittedly unpopular things that we've done over the first 2 years of the pandemic. I think that is increasingly not the case. And increasingly, while COVID is not the flu, we've been living with the flu over the past century, with community responsibility being that backbone. And while I really firmly believe that the mandates over the past 5 months have played an important role in helping our schools, keeping them safe for in-person learning in our communities, helping stabilize healthcare facilities, I think we're getting close to the point where the epidemiologic situation is safe enough and appropriate time to consider ending the mask mandates as one step in this transition from pandemic to endemic. Next slide, please. This is a late breaking piece before I welcome our superintendents, and I'll get out of the way here. I got an email this afternoon from the director of the Eagle County Health Department because a couple of our board members had asked me what has happened recently in places that ended the mask mandates. Eagle dropped their public indoor and their high school mandate on the 18th, 13 days ago. And at that point, the rate was just over 1,000. They made the decision as a board, I think it was about a week prior to that, when it was just over 1,500. 6 days later, the requirement for the other age groups and childcare centers, the 24th, was made. It was dropped then. So that's 7 days ago. The rate on that day had dropped down to levels that were actually just above where we are now. Since that time, and it's been a pretty short period of time, let's be clear, epidemiologically, the rates for all age groups have actually continued to decrease. That's what the graph on the right shows. In rates between 20 and 40, with decreases of between 20 and 40% each week. Positivity rates, what proportion of all tests are positive, have also dropped. Please note the graph. Heath Harmon is the director there, sent this to me. These are showing case rates in rates per 1,000, not per 100,000, even though the rates in the top part were rates per 100,000. So early returns from a part of the state that got worse slammed than we did by Omicron, who has recovered like we have pretty rapidly, who's now got about 10 to 14 days under their belt of having ended their mandates. Next slide, please. So it's my pleasure again to stop talking and to welcome two folks who've been fantastic colleagues and really in some way good friends. They don't know it, but I consider them that. And I'd like to, Lisa, let you drop the slides and invite Chris Kadowski and Rico Munn to talk a little bit about the issue of accommodating students that may be at high risk of COVID and what they've already been doing, but maybe more importantly, what they might do were mask mandates to end. And so, Chris, I see you first, so I'm going to call on you first and ask you to wax eloquent.
Thanks, Dr. Douglas. So I would just start out by acknowledging that all public schools serve quite a number of students who have significant health impairments. In Adams 12, our existing data shows that we have about 70 kids that are defined as medically fragile. They're often students at risk of a life-ending episode that's unpredictable, might require nursing care. We have over 1,100 students who have life-threatening allergies to things like latex or peanuts or other sorts of materials in school. And so we have quite a bit of experience of working with families who have a child with those kinds of significant impairments and their medical provider, healthcare provider, to determine what we should do to mitigate risk and accommodate those students and try to place them in the very safest position that we can at school. Typically, Seating adjustments are what we often do in cases where students have a peanut allergy. And I think there are some analogies to that situation to students who may be at high risk of serious illness with COVID. We often find really good levels of success in having students who have a peanut allergy sit with other students at lunch, to have students within the classroom not bring in peanut containing snacks to celebrate birthdays and other special events. And we're often able to group students close to other students who may be willing to voluntarily take some steps so that they're not exposing a friend or a classmate to something that could be dangerous to their friend. I would expect moving forward with high-risk COVID exposure students that we would go through much a similar process. We'd ask for medical documentation from their healthcare provider, see what the healthcare provider recommends in terms of modifications and accommodations to mitigate risk. There's certainly a number of things that we have in our possession, like KN95 masks that we have ample supplies of, that we can provide to students who might want them. If someone believed on the medical side that a plexiglass shield would be helpful to further mitigate risk, we have those in stock. We have lots of portable healthcare air filtration machines in every classroom in our system that we can either seat the student close to or move the student close to. So that's another level of protection. But beyond that, I really think that seating management is something that we commonly do for some of these other sorts of risk areas on the health side. And our experience is that through an interactive process with the student, the family, healthcare provider, the teacher, and students in class, that we can find ways to put students safely close to those who are going to voluntarily take steps that accommodate and mitigate risks to the student with the need. So that's how I would foresee this working. Have a lot of optimism given consultations we've done with other districts in the state and in the country that sort of process has worked well in protecting higher risk students from harm. And so we would plan to follow that model. One other thing I would just briefly mention, Dr. Douglas, is even if there were a change in masking requirements through Tri-County Public Health, I understand that we would still be subject to federal orders for students on buses. And so just know that that's a piece that we would plan to continue to do, is to require masking on buses, given that federal law requires it. But I believe we have processes in place that will allow us to safely accommodate other students with really significant risk in this area.
That's great, Chris. Thank you very much. Rico, could I ask you to offer some perspective?
Sure. Good evening, Dr. Douglas and members of the Board of Health. First, let me just take a moment to thank Dr. Douglas and all of his team for the tremendous partnership they've had with school districts throughout these very difficult 2+ years, really having access to them and to getting their insights and their willingness to understand the specific context of what we're doing in our schools has been incredibly important. I think that's the right segue to talk about that context. First of all, let me agree with everything that Superintendent Godowski said. We have similar numbers and similar measures in how we would approach our students and our families. We are already subject to requirements under federal law, under IDEA Section 504, for having an individualized discussion and agreement with families for how we might handle particular medical issues or access to education issues. It's very similar to what we've been addressing over these last several months for families who have medical issues that didn't allow them to wear masks. And so to a degree, we will flip those conversations and with students and families who present themselves as having a different medical need or a different access need, to address those on a case-by-case basis. Chris did a great job of listing what some of the particular accommodations might be, but they are very individualized, be it from a different seating or perhaps different bell schedules so that they're not going through a crowded hallway, or different accommodations that you might make for any individual student. We'll have to do those on a case-by-case basis. But we appreciate your willingness to hear about our context. Again, the CDC has identified 9 high-level strategies for how to prevent the spread of COVID. All of us have been layering those strategies throughout this school year and throughout this pandemic. We'll continue to have multiple layers, whether or not there is a mask mandate, as we do our best to keep our kids and our staff safe as possible. Thank you.
So thank you very much, Superintendent Godowski and Munn. Julie, if you don't mind, when I spoke with their boards at different points, they allowed the board to ask me questions so they didn't have to hang out for the whole meeting. And if you guys, if you don't mind, I would maybe like to pause and let our board members have a few minutes to ask questions they may have. And you guys are welcome to stay, but I didn't want you to feel like you needed to. So.
Yes, no, I think it would be great if we could have board members ask questions, particularly if there's education related questions. Let's push those up forward first, because I know our superintendents are really busy folks. Julie Schultz, I see your hand. Go.
Yes, thank you for joining us today. Really appreciate you bringing your perspectives. I think, Rico, at the end of your remarks, you mentioned keeping the teachers and staff safe, and appreciate you talking about the students. Absolutely, that is critically important. In reading a lot of the information related to the idea of removing masks in school right now, it's really dependent on vaccinations, and that's a critical part of being successful with removing masks. So I'm just curious from your perspective, if you feel that you have a high level of vaccinations, and could you just speak a little bit about feeling comfortable related to the staff and teachers as well?
Certainly. We were, I think, the first and maybe one of only 4 districts in the state to have a vaccine mandate for all of our staff. And so I am very comfortable about the level of vaccination of our staff members. And so we feel very good about that setting and that environment. We're also, I think, one of the few districts in the state that required athletes to either get vaccinated or tested on a regular basis. So at our secondary levels, we have, I think, higher than average vaccine rates because of all those student athletes who then opted into those opportunities. We've been very active in making sure that we connect our families and students with vaccine clinics and getting those set up and running. So I don't know on a comparison basis where we are statewide, because that data has not been widely available. Certainly, vaccine rates for our students are not where we'd like them to be, not as high as we'd like them to be. And that's not likely to happen without some state level mandate. But we have seen an uptick in that kind of over the last 6 months, obviously, as those opportunities have increased and as the CDC and FDA and everyone have seen those approvals. I think what we're hearing in this data tonight, however, is that the, what do you call it, natural immunity is going in tandem with that vaccination rate. So that's something we'll have to make sure we understand in our context and think about as we think about how we might apply or not apply different masking rules.
And I'll just jump in briefly. We didn't mandate vaccinations for our staff, but we provided a number of clinics on school property to provide easy access. And my recollection is that the data in early November showed that our vax rate was in the 92-93% range overall for staff, much higher levels for our administrative staff and educators, and a little bit less for our support staff, but really high levels overall. And we continue to provide vaccination opportunities periodically at the central office and at schools for staff and students and families who have interest in that.
Thank you.
One quick question that I had, actually, Chris, you mentioned KN95s that are available for students. Are those in pediatric sizes as well, or are they only in adult sizes? And then what do you do for those peds or those people with, petite faces for those masks?
So we do have pediatric size KN95s, and we disseminate those out of our warehouse to schools periodically. And if they start to deplete them, refresh them. I've not heard of any sizing issues where the pediatric ones have been too big for some smaller featured students. I just haven't heard about that. That doesn't mean that it's not been present, but it doesn't seem like something that's happened very often. In a case like that, we would plan to work with the student and their medical provider to see if we can get a special order mask that might be better fitting.
Perfect. Thank you so much. Just wanted to clarify that. Kaya, I see your hand.
Yes, thank you. I'm just curious what the policies are in place for testing, for contact tracing and quarantine students, because certainly with a contagious variant like Omicron, it must be very difficult just to stay on top of how many students are actually sick and how many teachers are sick.
So I'll go first on that one and then let Rico jump in. So in our system, in terms of quarantines, what we've been doing, and I believe that's true of districts throughout Tri-County's jurisdiction, is having quarantines move forward when we have outbreaks, which are 5 or more connected cases within a 14-day period, or if we have exposures following certain high-risk activities like in athletics, wrestling being an example. So those are the situations in which we've been doing quarantines. Contact tracing is something that, frankly, over much of the month of January, we've not done vigorously because the quantity of cases was so significant that we just didn't have staff to do that well. And my sense is that most, if not all, of our peer districts have been in a similar spot, that we just haven't been able to go through the individualized contact assessment that we were doing earlier on in the pandemic. Having a place where a change in masking rules doesn't change quarantine rules would be important to us, and I believe to other districts as well. In the past, we learned that if we had universal masking, we could use the five case outbreak level to determine quarantines, and it would be important for us that continue even without universal masking so that we minimize the number of students outside of school. And then finally, in terms of testing, we made a request to CDPHE for a variety of testing kits for 40,000. And today I received word that we received 39,600. So we'll have a lot of tests that we can disseminate to those who have interest in doing some testing. It will take us a few days to get those out in the field. I wonder a little bit, given what Dr. Douglas presented, if it's a little bit late in the game, but for those who have interest in that, we'll certainly have ample supplies of testing that we can get into the hands of families and staff.
And not to belabor the point, we essentially follow the same quarantine and contact tracing rules that Chris has laid out, because essentially that's what Tri-County has laid out. So we work in partnership around that. We've had lots of testing in our community from early on through COVID Check Colorado, and then we also opted into the CDPHE testing program a few months ago, and so that has been ramping up. We don't yet have that capacity around test to stay, and we're all learning around what that capacity will be. I think there's a state webinar on that in the next day or two, actually, to give us more details around that. But we've had significant testing throughout the community.
Thank you.
Thank you so much. Rosanna, go ahead.
Question for both Chris and Mr. Munn, I think it is. One of the comments I have heard in support of school masking from teachers and some family members that have provided a consistency for the protection of vulnerable students. It didn't make them the other, and it provided them some comfort in the school that they weren't going to be singled out. How do you plan? What is your plan, and where is your plan for the protection of students that do require masking or other remedies to protect them if a public health order is removed? And the second part is, what is your plan for education and preparation of families for a change of school masking public health order?
So I'll jump in on both. On the first piece, that is a concern that I hear people raise. We heard it back in the fall in August when we were debating what to do before the public health order was in place. And the very best approach that we could conceive of was to reinforce frequently, both with parents and with our students, that we want to be in a zone where no one's treated with disrespect or scorn or made fun of if they choose to wear a mask. And we actually had at some of our schools back in August, in the brief period of time before the public health order became in place. At some schools, STEM Launch being one that comes most readily to mind, 75 to 88% of our 7th and 8th graders voluntarily wearing masks. And so it felt like in that environment, and at that time, I think vaccination may not have been widely available to many in that age range, that message was well heeded, and the students who had risk assessments that made them believe they should wear a mask did so and felt comfortable doing so. At our other schools, as we started the school year, we typically had 15 to 40% of our students across our middle and high schools wearing masks early on. And so I thought we did a good job of sending the message that wearing a mask, if you feel like that's the right decision for yourself, and after consultating with your parents, that would be something that would be welcomed. And I'm not aware of any bullying or ostracizing or things of that sort that went on. So we would plan to handle it with similar messaging. And in terms of our plan, we're waiting to see what decisions the board makes tonight, but assuming there is action to adopt Dr. Douglas's recommendation, the benefit to this order expiring on Friday is that we'd have the remainder of this week and next weekend to do a lot of communicating to our families about the change and about some of the protective measures that we'll continue to have in place, and to talk about the accommodation process for students with more significant medical issues and starting that individualized process that Mr. Munn and I have been talking about.
And from our standpoint, going back to the beginning of the school year, we started the school year without a mask mandate in place, and we also were tracking with the voluntary mask usage, while it was a fairly high on the levels that Chris was talking about. My expectation would be that if this mandate were lifted, that there would still be a pretty high number of students and staff voluntarily deciding to do that, and perhaps it might decline somewhat over the semester as we get into warmer months and as people for themselves feel different levels of comfort. But I believe that we wouldn't treat this any differently than we do for the students we already talked about, who already have visible issues or impairments or access issues. We want to make sure we do everything we can to have a safe, welcoming environment for everyone to access their education in an appropriate way. As far as education, this will not be our first communication about a change in protocols. Those seem to happen, kind of every other week, if we're lucky. And so we will engage the same processes we've been doing to educate families about what the next step is, what the next step process is, and how we will continue to engage with them to follow the best medical advice that we can.
Great, thank you so much. So are there any other questions from Board of Health members, specifically for our superintendent, that we'd like to ask? Jan, please jump in.
Hi, yes, I'd like to thank both of the superintendents. I just have a question, and I just noticed a question similar to what I was concerned about. We've been talking and focusing on the children, which of course are very important in the schools. But if there are any specific measures that the school districts are employing to protect the teachers as well.
I'll go first here. What I would envision is a similar process for staff members who have significant health impairments. Certainly we can provide them with KN95 masks. Many of those staff members have also elected to be vaccinated. For some of the educators who had more significant health issues and concerns before, a number of them are working in our online program now. So I believe over time, because of a variety of measures, including vaccination and roles within our online program, the number of staff who have really significant health issues that would need further accommodation is much smaller, a very small subset. I believe that seating and proximity issues also fit well for staff, that if we had an individual who had a significant health risk to COVID, who's a staff member, we could ask students who are voluntarily masking to be those seated closest to the teacher, to determine if some students are willing to voluntarily mask while they're in that teacher's class, to be accommodating, We could have the teacher positioned in a place of the classroom where they're further removed from other students. So those are the kinds of things that I think would be most likely to happen.
Thank you.
And I would echo what Chris was saying, but I'll again point out, we started this school year without a mask mandate in place. And so we likely have addressed most of those issues. For any staff where that might be an issue, we would certainly be receptive to any follow-up because of something that materialized during the school year or any new staff members who may have joined us during the year. But I think we would have already addressed most of those concerns.
Thank you.
Thank you. Rosanna, I kind of saw your hand pop up there. You want to ask another question?
Yes, but I didn't know if someone else had another question. I was going to wait.
It's the first. Please ask.
Trying to do this done. Have either of your school districts been able to access some of the new dollars, federal dollars and state dollars and county dollars to mitigate and improve your ventilation systems in your classrooms and faculty areas as well?
The answer for us is yes. We spent over $500,000 on these portable units that are in every classroom and in many of our larger gathering spaces in multiple numbers. So we have those, and then we've also made some improvements to centralized HVAC systems in a number of our schools. We've improved the level of HEPA filters that we put into our systems. So we have used that federal dollars in significant ways to improve ventilation.
Do you do testing? So they're testing along with that as well?
We did some air quality testing early on as we made those changes, and we did some control groups to see what things were more effective than others in terms of mitigation strategies, and feel like right now we have the best technology in place that we were able to identify to mitigate risk and transmission of things within our classrooms.
I would say that we certainly have utilized, and I don't know whether it was federal dollars or where the dollars were, we've certainly utilized dollars to update HVAC in certain places and increase the use of HEPA filters. We were fortunate to be at a pretty high level of that at the start of this pandemic. We have not done significant air testing in our facilities, as you know, we relied on a lot of the modeling that we've seen around the country and the state around what that looked like and the impact of those things. But we feel fairly comfortable about the environments, obviously, that we've been in and that our schools have been operating in throughout this pandemic.
My hand is down, should be down. Thank you.
Thank you. All right, final questions for our superintendent. I'm not seeing any hands, so thank you so much for joining us this evening. It's been very, very helpful hearing both of your perspectives, and I appreciate you asking all of our questions as they've come up. You're more than welcome to stick around and join the conversation moving forward, but if you do have other things going on, I understand that too, but I really appreciate you guys being here tonight. Thank you so much. The next step I want to do, yes, Kai is clapping. The next thing I want to do is I want to open the floor back up to Board of Health members. Questions for John about his presentation, the data, the modeling, comments, anything. Do we have anything specifically for John we want to consider and kind of piece through? Julie, please jump in.
John, thank you for asking the superintendents to join us today. I know you engage with, there's many more, and you engage with them. I think what I heard was a lot of thoughtfulness from these two superintendents and a high level of vaccination rates. Do you have a sense if what we heard tonight is similar within the other school districts?
It's a really good question, Julie. I learned a lot. You guys ask more in-depth questions than we've had a chance to talk to the superintendents about. I would say that in general, the districts with whom we interact pretty regularly, which include Westminster, 27J from Adams County, and Littleton, Inglewood, and Sheridan, and Cherry Creek in Arapahoe County. My sense is they all have pretty common approaches. I've heard all of them, for example, talk about using the funding to improve ventilation. A number of them actually already had their own mask mandates when the year began. I think, although I'd have to confess, I haven't directly asked them about their ability to accommodate students. I will say that on our regular calls, they're now done weekly. They were actually started by Douglas County, the Douglas County superintendent. And then when Douglas County went to its own health department, Melissa Sager took over organizing those. We have had fewer contact with Mapleton, Adams 14, and there are 3 smaller districts on the plains that we've been less interactive with. But I would say in general, based on, again, not super in-depth discussions, but general pretty active weekly discussions, I think they all have pretty similar approaches.
Thank you.
Other questions for John?
Well, actually, I see Melissa there. I don't know, Melissa, you've had some sidebar conversation. Anything you want to add to that? Because I think
I'll just add that you did a very good job rattling off all of our school districts. I have been able to talk to the superintendent in Strasburg. We've reached out to those smaller districts on the plains. So while we're not interacting with them as regularly as our other superintendents, it's not that we're not interacting with them at all. And we've made all of them aware of this change and made ourselves available to chat through that. So yeah, I would agree. Nothing more to add.
Thank you, Melissa. Kaya, your hand.
Thank you. I'm just curious, Dr. Douglas, if you could just give us an overview of how Tri-County interacts with the school districts in terms of defining outbreaks, contact tracing, vaccine clinics. Could you explain the array of preventive services that Tri-County is providing to the schools?
Yeah, okay, good question, broad question. Let me sort of think about this in 3 buckets. We have a school team that has been working with the schools really ever since the spring of 20, very active last year during the return to learning, and been even more active this year. I'd say, first of all, while we certainly promote and share information about general mitigation and prevention strategies, I think you heard pretty clearly the schools are like super up to speed and frankly way ahead of us in terms of, not way ahead of us, but they've got very detailed understanding of what that takes. Nonetheless, there's still questions that come up that I think our school team has periodically been able to help with. The second question is the vaccination one, and that one's been very active. We do not have sufficient staff to go run frequent school-based clinics in all of our schools in all of our districts, but we've been working with lots of partners to do that. Tracy Anselmo, who was our community partnerships coordinator from the summer through about a month ago, and now Alex Kellogg, that I think some of you have met, has done a good job of working with those schools that are interested in school-sponsored clinics and helping develop strategies to do that. We had a little bump in the road last week when we had what turned out to be a kind of a fraudulent claim about underage kids being given vaccines without parental consent. That created a little bit of a hesitancy in some of our schools, but I think Alex has done a good job of kind of getting the schools over that. I'd say the most intensive really is the other one you mentioned, which is contact tracing and or a case assessment, contact tracing, outbreak investigation. This has been an enormously challenging area. So in the spring of 20, schools were basically, they went remote after the big first surge and didn't come back at all. When they came back at the beginning of the year, we worked really hard with them to help them understand the somewhat belatedly released state guidelines for how to do a case investigation and contact tracing. We worked very hard to get the state to modify some of the aspects of that that were frankly clunky and we felt, and as it turned out, interfere with in-person learning by resulting in too much quarantine. I think that process got better through the year, although we still felt that there were probably things going on that didn't strike an adequate balance between safety and keeping kids in the classroom. There were frankly too many quarantines going on. We worked very hard this year when school came back in to try to right size that even further and to try to work on, we didn't deviate from the state standards, but we did try to modulate them with some specific guidance that we gave the schools about how to define certain settings. And while we certainly have had cases of transmission in schools and we've had outbreaks in schools, I think we've been able to work with them pretty effectively on striking a balance of pretty high levels of prevention of in-school transmission at the same time allowing in-person learning. I would say that as one or both of the superintendents mentioned, the last, certainly 6 weeks have just been overwhelming with, again, record number of cases, and the ability to do meaningful contact tracing at the school level has been challenging, to say the least. We have had nursing staff who were previously working in this space who had to be called in to be subs in classrooms because they didn't have teachers to run the classroom. So I think that part of the equation is been somewhat rougher. I think we're still doing a reasonably good job of identifying outbreaks, but certainly not at the individual case by case level. I will say that our school team has been looking at sort of how to strike a balance if high levels of masking are reduced. I mean, I would hope that Chris and Rico's assessment that they might be at the 40 or 50% level would be right, but I think we all know they'll be less than what they are now. And what additional parameters can we work with them on to try to keep, again, the safety and in-person learning balance as clear as possible. The state is rumored to be modifying its own guidance. It got derailed by Omicron. The one thing that has come forth with that, Chris mentioned the test to stay program. Most of the districts do not feel like they have capacity to do that. That basically means if you've been exposed and you haven't been adequately vaccinated or weren't wearing a mask, that you can not have to stay out of school, but you have to do testing on a regular basis to determine that you can be back in. It's a very cool idea, but and there may now be adequate testing supplies, but there aren't adequate staff for most of the schools to supervise it. So, I mean, those are the high points of what's been a pretty complicated scenario and more or less where it stands now.
All right, Julie, I see your hand.
Dr. Douglas, I think, as I've looked at the current opinions that are out there, whether it's New York Times, Washington Post, NPR, one of the elements that seems to be consistent, and I mentioned this earlier, is vaccination. Our two superintendents were feeling that they had high levels because of their policies and procedures that they've implemented. Do you see that among all the school districts, or is that inconsistent? And this may be a difficult question to answer if the information isn't collected in that way, but I'm curious about your perspective.
Well, a couple of things. First of all, vaccination rates among school-age kids, whether it's the newly eligible 5 to 11 or the previously eligible 12 to 18, are way lower than we would like. And that's, we believe, pretty much true across the board. We've tried really hard to get good district-specific rates of vaccination. It's been really challenging because we don't have a denominator of who's enrolled in a given district. We've been able to use proxies for that by looking at census tracts that make up school districts, but that's a pretty imperfect match. We recently, I think literally last week, got information about actual enrollment, so we ought to be able to do a better job of that. I can't directly speak to the staff vaccination policies in each school. I know they've all been prioritized. I don't think they all actually have staff vaccination rates. I think and frankly, some of the districts have more resistance to vaccination than other ones. Melissa mentioned our smaller districts on the plains, and vaccination rates we think are lower in those census tracts. And I've talked to at least 2 of the superintendents, and they've got, more hesitancy in their population. So I think in general, vaccination rates are less good than we'd like them to be. They're lower in the more rural areas. And I think the schools have in general taken a pretty proactive approach to promoting student vaccination, but I honestly can't speak to specific policies they've done. And we hope that the more accurate than just really crude approximation of district specific vaccination rates might help them, but we haven't got those calculated yet.
Dr. Douglas, I might ask, sorry, Julie, I might ask a follow-up question.
Go ahead.
You did a thoughtful presentation tonight on the natural immunity, but when I think about children and while many people indicate there's less risk if you, in speaking with the American Academy of Pediatrics, their perception is that that isn't necessarily true. And being a pediatric nurse and thinking about this population, I have a high sensitivity to the idea that maybe Omicron's okay for children to get. So I'm curious about your thoughts on in the pediatric population getting Omicron and the influence of the natural immunity.
Okay, Julie, you asked a couple of things here. Let me see if I can do them justice. Certainly, I have not thought, I didn't think at the beginning from the data I knew of, and I don't think now that it makes sense to try to get Omicron. So I want to be clear that I don't think that's a good recommendation. For all age groups, there are severe outcomes. We've seen increased pediatric hospitalizations during Omicron, higher than we saw during Delta. It was not because it looks like that the hospitalization rate was higher or that the severity of infection was worse, but just simply that many more kids were getting infected. So ideally, I would like for none of the kids to get infected. Having said that, if at least 42%, that's the statewide estimate for everybody, and it's probably higher in the unvaccinated kids. If 42% have gotten infected, at least initially that immunity ought to be as good from everything we've seen in the studies that have been produced so far as vaccine-induced immunity with a vaccine that was not made to match Omicron. Now, duration is another matter, and breadth of response is another matter. And I would not at all want to say that a kid who's had Omicron is good to go, no need for a vaccine later. If a kid who's eligible has gotten Omicron, I think they should get it as soon as possible. That's what I told my granddaughter. If a kid who's under 5 becomes eligible in the next couple of months and they had Omicron, I think they should still get it. I say that based on the fact that we don't yet know the results of those trials and the safety data, et cetera. But if the safety data pans out well enough for the FDA to authorize it, I would still make that recommendation vis-a-vis the natural immunity. I still worry about, in all of our populations, the long COVID dimension. There have been lots of claims made, kids don't get long COVID. I don't think we know nearly enough about that. I do worry about that. So I think there are clearly a number of concerns. I guess I pointed to the immunity because it was, for a terrible thing, it was frankly in some ways an unexpected collateral benefit that again might have preferentially helped the unvaccinated.
Rosanna, go ahead.
Hi, I have a question. It's part of Melissa's question and part of John's. You had mentioned, Melissa, some of the smaller school districts out on the plains. But in Adams County, have we heard from the Commerce City School District 14? You did mention District 50, Westminster. And the reason I'm speaking to that is because our issues of health equity. As we all know, people of color have a much higher morbidity mortality for COVID overall. And Commerce City and Westminster being the majority, well over 80% of students of color. Mr. Munn, I didn't ask about the Aurora schools, but they have significant populations too of students from families of color. So what are we hearing from Commerce City then, District 14? Where are they at in the mitigation efforts?
Yeah.
I know there's a lot going on, but do we know?
So Dr. Douglas mentioned Westminster, and Superintendent Swanson is a participant on our weekly conversations with superintendents. She doesn't make every call, but we connected. All of our schools are chatting through with us mitigation measures, some more frequently than not. When we have touched base with some of our school districts, they've explained that they feel comfortable with the mitigation strategies that they've implemented. As John mentioned, it's very complicated, working with all of our school districts on guidance to respond, but we work with them closely in outbreak situations and implement mitigation measures closely with them there. I have not been able to connect with Adams 14. I did reach out, but wasn't able to get through to anyone. But we're emailing them regularly with these updates, and all know how to get a hold of us through a variety of different channels. But again, in our conversations with them specifically about mitigation, they have felt comfortable there. John, I don't know if you have anything to add.
Well, I mean, look, honestly, we've tried hard to sort of connect with as many as possible, and we've had really good connections with some. I think Adams 14 has been a real challenge. Our school teams have had interactions with them on management of cases that they think have gone pretty positively. And we can certainly get their collected wisdom and get back to you. But I would say it is an area that has gone less well than we would like in terms of communication, Rosanna.
Yes, because they've historically Commerce City, and that's really where I was trying to target my question. And I could always do that better. Communication with families has been a big challenge in other areas in District 14. Yeah. So I would ask that we make extraordinary efforts. I know, Melissa, you're working hard on that, but whatever channels you can use.
Yeah, I don't know if
Alex. I'm very
Alex
concerned about communication to families and education on where they're at and where we're going.
Right. I don't know if Alex Kellogg is on the phone. Alex is our partnerships coordinator because she's been working with our school vaccine efforts. We didn't invite her. So Rosanna, it's a really good question. We'll see if we can get you better information about that because it's not one of our most stellar areas of collaboration.
All right. Other questions or comments from the board that we'd like to address? All right. I'm not seeing anything, John. So should we move forward with
yeah, maybe we can. Sure. Why don't we go back to the slides, Lisa? I was actually through the end of my presentation, really good timing to get all our questions. And I do have a proposed motion for the board to consider if Lisa can bring that back up. Is Lisa still on? Is anybody? Oh, there's the parrot. So there we go. Thank you, Julie. So this is the motion that I'm recommending to the board after the discussion that we've had, basically to authorize and direct me to let expire and or rescind after Friday, the 4th, the public health orders that require face coverings for all individuals 2 years of age and older in public indoor spaces, and the school mandate in particular face coverings all individuals ages 2 and older in schools and childcare settings. With the idea that while we badly do not want to go back down the pathway of future public health orders, we do want to be realistic. And given that being able to issue public health orders in a last ditch situation can be important, this would not preclude us from issuing public health orders in the future. I would note two things as I make this recommendation to the board for their consideration. I think it would be preferable if both of these separate mandates could be considered together. In several of our neighboring counties, particularly Boulder and Jeffco, they have been consolidated. We chose not to do that, but I do think that there is a fair amount of logic connecting the two. And I think there is a fair amount of understanding of the public kind of communication if they are taken together. Denver just decided to withdraw their public indoor mandate this afternoon. And I'm a Denver resident, beginning to hear a lot of some of the resulting confusion about them being handled separately. I would say that if we do have metrics, as you all know, for the first order, we do not have metrics for the second order, although we discussed possible metrics in earlier meetings. If the second order is, if the board decides not to follow through on the recommendation about the second order, then I would like some guidance from the board about parameters that might make sense about the duration of continuation of that order. And the third minor caveat to point out is that if we end up not doing them sort of in aggregate, that is, they both are expired or rescinded, or they're both allowed to be continued, and that we end up doing them separately. For example, if we do it like they did in Denver, I guess actually, sorry, let me reverse that. If for some reason the school mandate should be voted to be discontinued, but not the public indoor space mandate, we would need to modify the public indoor space mandate because it would cover indoor places that include schools. So I probably just garbled that. I'm sorry. Let me repeat it. If the school mandate were to be ended, but not the public indoor mandate, we would then need to amend the public indoor mandate to exclude schools to accomplish the goal of no longer having mandates in schools. Does that make sense? You're nodding, Julie. Did I avoid butchering at that time?
That did help. Yes, thank you. Thanks for that repeat there.
Yeah.
All right. So Tom, I see your hand.
I would like to move to authorize and direct the Executive Director of Tri-County Health Department to let expire and or rescind after February 4th, 2022, public health orders requiring face coverings for all individuals 2 years of age and older in public indoor spaces, and face coverings in all individuals ages 2 years and older in schools and child care settings. This motion does not preclude Tri-County Health Department from issuing public health orders in the future as conditions may dictate.
Thank you, Tom. I have a motion. Is there a second from this group? I will second that motion. So opening up to discussion regarding the motion that's on the table. Thoughts, questions from the Board of Health? Julie, please jump in. Oh, Julie, are you muted?
Thanks, Julie. Dr. Douglas, you talked a lot about the modeling and that in just 2 weeks, we should have a lot of lower cases, lower hospitalizations, increased immunity. And we didn't talk a lot tonight about older citizens. So now that we're bringing these together, the new CDC, and I'm looking at it over here, information indicates that unvaccinated individuals 50 to 64 are 46 times higher, have higher incidence of being hospitalized, and for 65 and older, it's 52. I'm curious your thoughts about, because our trajectory is heading in the right direction. If we waited for 2 weeks, and I'm asking you to speculate, do you think that would be supportive of older members of our community?
So let me be sure I get the question, Julie. If we waited another 2 weeks, would the vaccination rates or the booster rates, you might, I guess, add, be likely to increase in those groups that
So
are?
the natural immunity and the fact that that Omicron is the number of cases are decreasing, so there won't, we won't have as many cases and therefore less risk.
I don't know how to answer that. And the reason I say that is I asked the modeling team if they could give me age-specific breakouts of likely percent infected. And they gave me a very rough outline. They said it was likely, and it didn't show really major age gradations. The only caveat they put on it was that because infections were more likely to be asymptomatic in younger kids, they thought that was probably the group that was most underestimated. But I don't really have any better information, which is all to say then the projected rate of increase in infection is likely to go up in those older folks, although by how much, it's a little hard for me to say. Part of the reason I say that is the state projections are based on the entire population. And you might wonder, how are we going to go up so high as a state if we're going to be dropping so rapidly in the metro area? And the answer is we're probably going to have, I think, a whole lot fewer natural infections in the metro area going forward, just because we've got so much less infection going on. I think what's really bringing those state averages up is parts of the state that are still not sort of haven't hit their peak yet, or at least they're not as far past the peak. All of that is to say, I'm guessing we'll have some modest increase in natural immunity, but in the next 2 weeks in that group, but I don't think it'll be very much.
Julie, does that help? Any follow-up questions before we move on?
No.
Okay. Okay. Jan, go ahead and jump in.
Yes, we now have them both in the same motion, I believe I heard from both the things we were considering. I'd just like to make a comment that I think that we need to keep them both together because it's very difficult, as well as confusing, for people to know when their children should wear masks and when they shouldn't. So it should either be, I think, entirely together or one thing or the other for both. And then I was going to ask Dr. Douglas to reiterate that my thoughts are that no matter where this vote go, well, it's not no matter, but if it does go, that it gets lifted, that people are still encouraged and still should be wearing masks when they don't feel comfortable or if they are vulnerable to protect themselves, even though we have other mitigation efforts.
Jan, really good question. And that's absolutely going to continue to be the case, that CDC and CDPHE are still recommending masks in public indoor spaces. CDC and CDPHE are still recommending masks in schools. Some schools actually have their own policies in place. I don't know how many others will consider implementing them. It's possible they will. We certainly would be supportive of that. But we will be continuing to message very strongly that what this transition, were it to happen, means is not masks are not needed. We don't recommend masks, but rather we think we're at a sufficiently appropriate time epidemiologically and with prevention tools that the value of doing these various mitigation things can be carried out based on institutional choice, churches, businesses, schools, et cetera, or individual choice. So they remain very important. And I think, honestly, it'll be really important for us to keep reminding people if new variants come, we may have to go back to some of the old playbook, not necessarily public health orders, but even stronger recommendations about masking.
Thank you so much, John. Did I see your hand hopping up there and going down again? Do you want to jump in here?
Yes, just the one comment. I think maybe as a matter of consistency and clarification, the word in on the second line there after coverings might be changed to read for, so that they're both the same. They both should say coverings for.
Good point.
Got it. Thank you. Rosanna, I see your hand. Jump in.
Hello, I'm looking at the date of the 4th. You know, input that I've received as well from teachers and some staff is that requesting more lead time. John, you had talked about Denver Public Schools was not going to lift their public health order for schools until spring break. That's just, and evidently they changed their mind, I guess. Is that what you're saying?
Well, no, actually what happened in Denver was just the indoor mask mandate, not the school mandate. Now, I know there have been conversations happening about what is the appropriate time, and spring break has been mentioned, Rosanna, but I don't have any inside information as to whether that's in fact the plan or not.
Okay. I think teachers and staff, they need more lead time to prepare. As you said, consistency was one of the benefits of the public school mask orders. And keeping kids in school is a goal that we all want. We all want kids to be in school. So I would ask that we take a look at another date, not the 4th. But that's open for discussion.
All right. Thank you, Rosanna. Tom?
When the order was first issued, it had an expiration date at the end of January. This wasn't ordered last week. It was ordered last year. I think people have had more than ample time to get ready for a discontinuing of the mandate. Extending it further than just the rest of this week, I doubt is going to give anybody all that much more time to prepare. They're pretty well prepared already, especially the parents who are anti-mask, and even those who are pro-mask and have seriously ill children. This isn't something new. You know, we did this before the pandemic. We had people who had cancer. We had people who had immunosuppressed situations. Extending this every few days, every few weeks, every few months doesn't improve the situation, but does diminish the public's trust in public health.
Well, I think I would differ. As I just said, teachers and people who work in the school districts have provided comments, and they're direct opposite Tom, and I think they're the ones that are best able to judge what's going on in the schools.
All right, thank you. Julie Shields, please jump in.
And I wanted to respond to that as well. Dr. Falwell, I think in the past, you have been hesitant about some of the projections, and much of what we talked about tonight is based on projections. And just want to clarify with you, it sounds like you're supportive of the data and the analysis that we've heard tonight and the direction that the projections are going.
It's not just the projections. The viruses that we're faced with now are different than when the projections were made for Delta. Delta was much more virulent. This one isn't as virulent. This one is more transmissible. We're not dealing with the same variety. And CDC guidelines have or need to change in the face of differing levels of transmissibility and virulence, as well as differing levels of relative community immunity, especially natural immunity, which may be, as Dr. Douglas pointed out, may be a benefit to Omicron in that it doesn't allow Delta, and it does give a level of natural immunity. So it isn't just projections, and it isn't the projections that we discussed previously that were based on Facebook call-in results. It's funny, we don't trust people to wear masks, but we trust them to call in and tell us how often they're wearing the mask. That always struck me as strange too. But we're not dealing with Delta anymore. In the future, we may be dealing with something that's even more deadly than Delta. And we'll have to change direction again. We shouldn't paint ourselves into a corner with regard to our response to a disease.
I appreciate, thank you for responding and giving Dr. Douglas a break.
All right, other thoughts from this board, questions and or comments that the group would like to make before we do a vote? So I'll jump in. I really just have a comment that I want to share, and that just how difficult this decision is for many of our board members. You know, keeping we've had the best of intentions over the course of the past couple of years. Nothing any of us anticipated we'd even have to have a discussion about when we joined this board. But, you know, I really appreciate the efforts of this board and the Tri-County Health Department staff of keeping our community as safe as possible. Personally, this is a really impactful vote for me. As you guys know, I do have 3 young kiddos that are in public school. So this directly impacts my life and how I send my kids to school every day. And so one of the things that I feel comfortable about, as you might mention, I did second this motion, so I do support it, is, you know, we will continue as a family to take the appropriate precautions to keep our kids safe. Our kids are vaccinated. We wanted to make sure that we gave them as much protection as possible. And so that's something that was really important to us. You know, vaccines have been available for 3 months now and readily available. And I encourage members of our community continue to get their kids vaccinated. One of the things that we've seen, that I've seen personally, is how adaptive our school districts have become over the past, especially year. You know, I had one of my kids' class went on quarantine a couple months ago. And, you know, just like that, her teacher was able to give her an online curriculum for the couple days that she was going to be out. And, you know, we kept on without missing a beat. And so, you know, families, that's what we do. We keep going, and our schools help us get that work done. So I feel like that relationship with the school has been really helpful. And listening to the superintendent tonight has been really valuable for me to support this motion. I want to open this up. Any more Board of Health members' comments or questions before I call for a vote? Go ahead, Jan, jump in.
Thanks, Julie. I again would like to reiterate what you said. This really has been a difficult decision, as it was to instate the mandate. And I appreciate all the board members, because we have all had many discussions about different views, and we all have given very much thought to it with our experience and our professions. I would like to thank those people who have taken the time to write respectful, thoughtful emails to us, because we really have seen them. We just not have had the time because there have been so many. But I appreciate that, and I want to recognize them for what they have taken the time to do.
Yes, thank you, Jan. That has been, we have received hundreds of emails, it seems like at this point, of people advocating on both sides. So I know that this is a very important topic for our entire community. Okay, well, at this time, I am actually going to ask for Renee's help in doing a roll call vote for the motion that's on the table.
Okay, so Julie Malika,
Yes, I support the motion.
Rosanna Reyes,
No, I do not.
Julie Schills,
I will say that we have been doing a lot of research, and this has been something that we've all been researching very carefully. I would also like to thank the Tri-County staff, as well as those who submitted very respectful and thoughtful comments and pieces of information that we could consider. At this time, I will support the motion.
Jan Brainerd,
I would just like to say that a few things. Sometimes you have to change strategies. It doesn't mean that you were wrong. This was meant to be a temporary, not a long-term mitigation measure until other mitigation efforts became available. We do have more infrastructure in place for such things as vaccines. We didn't talk about the pharmaceuticals. We did talk about the testing, et cetera, to keep the kids in school when it comes to school masking. With mounting scientific evidence and data indicating a significant decrease in cases and continuing to trend downward, I believe it is time to allow the most difficult to carry out of all our efforts, mitigation efforts, to expire in the hopes that the people will continue to follow those efforts to protect themselves in the community, and so I support it.
Dr. Faywell,
Yes.
and Dr. Gallagher.
Thank you, Renee. I support the motion to let the two mandates expire. I'm encouraged by the latest COVID trend data. And at the same time, it's clear that COVID has not gone away. And I do hope that even though we are ending the mask mandates for everyone, that does not mean that we can afford to stop being vigilant. If anything, in fact, not having a global mandate means that we should all become even more aware of situations where there is a high risk for COVID infection. So with those caveats, I do support ending the mask mandate.
All right, thank you. So the motion passes. Moving forward, we don't have any other items to discuss. So we do have another board meeting next week on February 10th. So we'll see each other right around the corner. Can I get a motion to adjourn this meeting for this evening?
So moved.
Second.
Thank you so much. All in favor?
Aye.
Any opposed? All right. Well, thank you, everybody, for your time this evening. Thank you, John and staff, and as well to our superintendents who joined us, and as well as everybody from the public who called in and on this very important issue. Have a good evening, and we will see you all soon.